Thank you very much. I'm honored to be here to moderate the first session of the Symposium on the dissatisfied patient. As Helene said, no one has one. All the dissatisfied patients are made by someone else. However, as we know, there are some reasons why patients after hip and knee arthroplasty are dissatisfied. Sometimes we have done bad surgery or bad other things. And of course, these are an issue by itself. However, today we're going to talk about more subtle reasons behind dissatisfaction. What we can do, why are they dissatisfied, what are the reasons behind dissatisfaction. And we have the honor to have three guests here to give them presentations. The first one is Leo Whiteside, as most of you know, as the man behind the Whiteside line. However, he himself called it the AP line. And also, most of you who do knee surgery, of course, know everything about the ligament balancing. And perhaps some of you also know that you should always put in the implants uncemented, both hips and knees. He starts with the presentation, his views of on this topic. And after that, we have two Swedish speakers. First, Sara Gardenstam, who has interviewed patients who had late cancellation of a planned surgery, which is not so uncommon in Sweden, unfortunately, and to hear how they feel about that and what that might lead to. And finally, Amir Mahdi, currently working in Södertälje, but doing his research in Örebro. He has interviewed 44 patients who claim to be dissatisfied with the surgery. And he's going to tell us the reasons behind and what we perhaps might do about it. So please, Mr. Leo Whiteside, the podium is yours.
Thank you, Jeff. First of all, let me say thank you so much for inviting me to come here. I love this beautiful city. It's a great opportunity to be in Sweden, one of the most beautiful places in the world for so many reasons. And also a very comfortable and friendly place. Thank you for inviting me, Elena, especially all your work put into getting this to happen, and for giving me these interesting and challenging topics. I mentioned earlier that to my host that I said goodbye to my wife about 3 months ago in order to prepare for new topics. You know, it takes forever to prepare a new topic. And the last thing we want to do is talk about our problems. So I did do some work to get ready for this, and I looked at my last 5 years' experience and to look at both the hip and the knee. Now, these aren't hard numbers, and this is not a publishable study. This is my experience only, so please don't give this too much credibility. But what I found was kind of what I remembered. 55% of these failed, swollen, sore total knee replacements, and I was sure something wrong with it, were cement failure. Cement to bone or cement to metal, and I'll talk more about that later. Unbalanced ligaments, 20% of these cases, not 20% of all the knees that came in, but 20% of these swollen, painful, difficult knees that you don't have a diagnosis for sent because of no good diagnosis. Polywear, pretty common. Metal sensitivity in my practice, not uncommon because I'm a referral center for metal sensitivity and I'm very much aware of it. I'll talk more about that later tomorrow. Infected, again, I get infected knees from all over the world, really, but mainly all over the country of the United States. And fibrous ankylosis. Fibrous ankylosis is another one of those diagnoses of exclusion. Let me go through just some cases to discuss this and some basic rationale. I don't know if you know Dr. Schmaltzried. He's a great advocate of cementing everything in the world. And I think he's a little bit embarrassed by the fact that one of his papers shows very well why and how cement doesn't work, especially when pressed into cancellous bone. This interface here that is exposed to joint fluid becomes inflamed, gradually erodes both the bone itself and the marrow, leading to progressive loosening that can't be prevented when you have an implant that contracts inside a joint, and they all do, don't they? The other place that you have to look that's an active interface is the bone cement interface. Now, this is an autopsy specimen, and the author of this study is Mark Miller, a bright and very erudite master at what he does. He's a biomechanical engineer who started out as a mechanical engineer, extremely well educated. So I would give these studies of his great credibility. So if you get a cadaver specimen early, it looks like this: deep penetration of cement into bone and viable trabeculae, what appear to be viable trabeculae everywhere. If you look at them at about 2 years after surgery, where there used to be trabeculae are now empty spaces. The trabeculae have retreated. If you go to 5 years after surgery, all of the cement mantles have wide expanses of all fibrous tissue. And you can see up here where the bone used to be, and down here is where the bone is now. And it's interesting that this interface, this fibrous interface, is often not visible on the radiograph. So it's easy to miss these on the radiograph and misdiagnose the patient. Also, failure of the cement to bond to metal. There have been several good studies on this. This is one by my friend Michael Reese, debonding of the metal component from the cement, especially in the tibia. And he actually identified many of these radiographically. You can see this difference on follow-up. Debonding of the metal to the cement. His is not the only report. This is the report from the Mayo Clinic group. You probably know Pagnano's and Hansen's name. Very strong advocates for cementing everything in sight. Still, they see debonding. Here's a series of radiographs from their article, not just debonded, but also failed migrating and attendant osteolysis. So, serious failure. The cement often looked intact. The implant lifted right out. And my own experience with this is similar. Interesting that they almost always have a normal or slightly elevated C-reactive protein and sedimentation rate. The bone scan is variable, sometimes high, sometimes low, not reliable. I think as bone scans are in general, not reliable. But almost always a large effusion, white blood cell count less than 5,000, mostly mononucleated. And when you see a painful knee come in with this, seen by several doctors, and especially the doctor that did the operation, saying that the knee looks fine, and looking at this interface saying, this looks like a fine knee to me, I don't know what's the matter with you, and I can't explain the effusion. I can usually explain it because I've seen it so many times. It's cement debonding from metal. This is the way it looks. This implant comes directly off. Underneath it, the cement is broken up. Cement certainly does not stick well to metal. If you want cement to stick to metal, it must be mechanically interdigitated. It would stick best to a porous coating. And when we first started cementless joint replacement, that's the way we got our implants past regulatory. It, as a matter of fact, makes the cement much more effective if the cement is really bonded to the metal through a porous coating. It gives it about 5 times the overall strength of this complex of metal, cement, and bone. This is a major failure. The patient cannot ignore this, will not get better, and it takes sometimes decades for the x-rays to declare themselves. Interesting, if you look at the cement underneath there, what you often find is, in fact, almost always find, is the cement is broken up, and in just a couple of places, the cement is still adherent, but adherent through a dense, fibrous interface. So this cement mantle that looked so good on the radiograph was not so good. And it also happens on the femoral side. Oftentimes you can't really see the cement on the femoral side because of the angle of the x-rays and because of the housing and the posterior stabilized implant. But what you can see of it looks fine. The patient kind of looks all right. And everyone is getting concerned about the patient's credibility. I assure you, when you enter a few of these knees, you begin to trust the patient. If it hurts and swells, this is so common, at least in my practice, debonding of the cement to metal. Cement does not stick to metal. It is not a glue. It is a grout, and there is nothing for it to grout into. And the cement often is broken up as well. So this is failure of a cement bond to bone and a cement bond to metal. This is 1950s technology, guys, and we are, I think, are still struggling with it. The next most common problem that I see in the knee is unbalanced ligaments and malaligned knee. This is commonly due to the so-called kinematic alignment or constitutional varus, or as they're calling it now, gentleman's varus. Please stop it. It's associated with wear and loosening, and the joint is not likely not to make it. This is one that was sent to me by a referring orthopedic surgeon who saw nothing wrong with this knee. He felt it was fine. Now, I will tell you that it felt very stable when you just rocked it a little bit, but if you grabbed it and gave it a strong valgus stress, of course, this lateral space closed, and the knee clearly was left in varus. The bones were cut in valgus. The knee was left in varus because the doctor was told that if you use my instruments, you don't have to touch the ligaments. Please, stop it. This knee was obviously tight medially. I talk more about this knee later on this week. Tight medially, worn polyethylene post, big wear on the medial side of the knee, clearly not right, and as you might suspect, debonded cement from metal and debonded cement from bone. Not at all uncommon, much more common than you might think. Wear and total knee replacement is generally thought of as polyethylene wear. And again, if you see wear on your total knee, you know it's by thinning those spaces, and that the treatment for that, if you can save the metal implants and the cement bonding them, is to just exchange the polyethylene and correct the ligament balancing problem. The other issue is metal wear. Now, we're pretty much stuck with these metal implants and metal scratches. This is cobalt, chromium, molybdenum, nickel implant, and it scratches. Those scratches and the surface itself release debris and ions. They contaminate the joint, and these are toxic contaminants. And some patients, like this coal miner that I took care of, get 10 years out with a knee that swells and hurts and starts to wear the polyethylene at a higher rate. Again, this is toxic metal. Cobalt, chromium, molybdenum, and nickel in industrial quantities put into your knee is remarkable to do to human beings. It's amazing that we do get by with it. Now, these scratches can be identified and characterized very, very well with light profilometry, various types of light profilometry, characterized and their volume measured. It's not an insignificant volume of metallic debris that comes off of these surfaces. In fact, if you look at it, it's measurable, even at 5,000 cycles in a wear testing device. None comes off of a ceramic surface. And metal shedding into the joint is probably much more than we've been able to measure, and it continues throughout life, and it's generally worse in real life than it is in the wear simulators. This metallic wear, I think, is a significant issue in orthopedic surgery, and I think we ought to address it. Most femoral components do roughen, and it's been studied very well. You can find studies from very good labs. Claire Remnack's lab is highly reputable testing lab in the United States. Metal toxicity is a significant issue in joint replacement. It is a significant issue. I know it'd be much more convenient to ignore it, but it's just not the fact that you can ignore it. Chronic pain and swelling with no sign of loosening, malalignment, or infection, if you have a metal surface in there, is well likely to be that metal surface. Stiffness, hemorrhagic synovitis, eczema, hair loss, and vitiligo, all reported, very commonly reported. A skin patch test is not very effective, at least in some people's hands. Now, you'll find the literature is variable. Skin patch test and lymphocyte transformation, not very good as a predictive factor. But if we keep looking, we find that preoperative patch testing is strongly associated with postoperative pain and loosening. Clinical history of metal allergies strongly correlated with poor outcome in total knee replacement. History of metal allergy is strongly correlated with outcomes, especially in females. This fellow, Bob Barrick, I know very well. He's a colleague of mine at Washington University in St. Louis. Postoperative positive lymphocyte transformation test is strongly correlated with pain in total hip and knee, especially in female patients. These guys, Josh Jacobs and Nadim Halab, are the world's experts on this subject. I think the credibility is there. Now, I would like to share my personal experience with 7 patients with 6 to 12 years follow-up. These were patients that were referred to me, highly selected, and I decided to operate on them only with distinct symptoms and signs, not just hurt, but effusion, recurrent effusion, sometimes hemorrhagic effusion, eczema, and a positive lymphocyte proliferation test. So these were highly selected patients with clear metal sensitivity. And I'd like to just give you one of them as an example. I will tell you that every one of them was operated, and every one of them got over the problem. My impression is metal sensitivity is a big problem in hip and knee. This patient has severely painful knee, bloody effusion, well-fixed implants, but negative workup, and this is her test for nickel sensitivity, dose-response curve, and off the charts with the higher concentration. This was her effusion, hemorrhagic synovitis. The synovial membrane was terrible looking, hemorrhagic. The implants were well fixed to bone. And I can tell you, I worked for some time, finally pried them off, both of them well fixed to bone. This was not a loosened implant. It was a bone ingrown, porous coated implant, bone ingrown on the femur and the tibial side. This is our solution, a revision total knee replacement made of ceramic with a porous coating and a taper with a titanium porous coated stem. This is put on very gently. I think you can imagine hitting a ceramic implant that you only have one of, especially with a stem on. So we tap gently on that for sure. There we are finished, and there's the finished product. About 3 months after surgery, at a year after surgery, she came back to my disappointment with severe pain, but she had this as well, and it was only anterior knee pain, no level ground pain. So here is her open knee. We're opening her to take care of the patella. Notice that the synovial membrane is not hemorrhagic. This is a very benign looking synovial membrane. The implants are very tightly bonded to bone, femur, and tibia. The patella had a lot of work to be done, to be trimmed up, and finally matched back to her femoral component. Now again, this was this is with the first operation, And this is the synovial membrane with the second operation. I think you'll agree there's quite a difference between the effect of ceramic and cobalt chromium on this patient's knee. Her knee clearly showed signs of stress relief distally, osteointegration into the porous surface. Her patella was doing well, and I can assure you she was delighted with her outcome. Painful limp after hip replacement. Spine. When I hear what we got in the next room and it's painful hip, sent in after hip replacement, or one of my old patients, years after hip replacement, it's lumbar spine 80% of the time. Also, loose implants occasionally. A short femoral component in anterior approach total hip replacements, metal sensitivity, metal on metal, and this has shrunk recently, thank goodness, because they're not putting those in anymore, and abductor malfunction. Very important. Untreated abductor muscle is a very important part of the hip. Posterolateral pain years after surgery. If you look at that x-ray carefully, I don't think you can miss that those nerve root canals are closing. If you have any question that these nerve roots might hurt the hip, look at your anatomy. I can assure you there's plenty of reason. Painful thigh and knee after total hip replacement. I want to recommend serial x-rays. These are at 3 months and 1 year after surgery. No difference. These are at 10 years and 11 years after surgery. Patients still miserably in pain, and the x-ray is still being read as negative by his referring doctor, and the bone scan is kind of hot. Now, if you look at 3 months after surgery and 11 years after surgery, then you see the difference. Serial x-rays 1 year apart are not very effective for this. 10 years apart, they are. My point is, like in scoliosis clinic, look at the x-rays over the long haul to see what's happening. Metal on metal bearing. This patient was referred by the referring doctor, by the operating surgeon, with a painful right hip. Now, that ugly looking left hip is actually doing very well. This is the one that looks good but hurts. Hurts and won't stop hurting. Scratched and abraded femoral head, a bone erosion, hyperemia of the bone where it's been removed. And here we are removing the metal liner, putting in a plastic liner and a new polyethylene component, and the patient takes off on this with great pain relief. I recommend operating on these patients if they hurt after metal on metal hip or with taper damage. I hate to mention names, but if it's a Zimmer taper, it's probably going to look like that. And if it hurts and hurts and hurts, they've got a fluid in their hip that has a lot of macrophages, eosinophils, and basophils, and I would go for it. And I would replace that metal implant with a ceramic implant. Ceramics are much easier on the taper than our cobalt chromium implants, no matter how the taper is made. And finally, lateral hip pain and worsening limp. I've recently done some work on failed abductors in total hip replacement and the posterior approach doing abductor repair and a gluteus maximus flap transfer. Literature review actually shows that if you look carefully at the abductors when you're in doing the total hip, 10 to 20% of them have demonstrable damage to the abductors, closely correlated with pain and limp after surgery, but simple repair has not been very effective. My personal experience in looking at patients really carefully is about 20% have abductor tendon damage. The important thing is about 85% of these were undetectable without dissecting through the deep layer of the greater trochanteric bursa. And then repair and reconstruction of that has been successful. This is what I like to see. This is a normal gluteus medius, minimus, and greater trochanteric bursa area through a posterior approach after the hip has been done. Those abductors have been respected in all ways. The bursa itself is minimal, not a big issue, and these muscle fibers have not been disturbed by my operation. Now, this is an example of one with mildly detached and pretty good muscle underneath it. severely detached with good muscle, and one with severely detached and poor muscle that I found in an earlier study. Now, I want to use this case to illustrate something here. It's maybe not clear that this muscle is in trouble, but notice it has a lot of fatty infiltration, and when you put a suture through it, it's a big hypertrophic bursa. If you take that suture out, split that bursa open, and look inside, you're likely to find a vastly different looking abductor system. In fact, the gluteus medius and most of the minimus, or in fact maybe most of both of them, as in this case, are disrupted. But this muscle still looks like it could get better with surgery. This is a right hip, by the way, so this is posterior. A palpable osteophyte here, dense bursa, and the muscles don't look quite right. If you split right over that osteophyte, not uncommon to find a defect in the gluteus medius that is repairable if you just do a simple repair, and does much better if you do a gluteus maximus flap transfer. This is done with some surgical technique, not just a couple of suture anchors, and cannot be fixed adequately arthroscopically. Sutures through bone, through tendon, and then with a gluteus maximus flap to add to that repair. Posterior approach is something I'd like to promote worldwide. It allows hip replacement to be done without adding damage to the abductors. Remember, first do no harm. It allows full exposure to the greater trochanter and abductor attachment for repair. That allows repair and reconstruction, and also allows you to clearly identify the problem. I realized this was somewhat disconnected, and I think the subject is amenable to a disconnected approach. There are a million different ways things can go wrong, but I will tell you that through my entire last 5 years that I looked up, I didn't send anybody out that I didn't have a diagnosis for. Now, maybe I made it up, but in general, I think we should be careful not to shoo the patient away, but in fact to look. In most of these cases, they do hurt for a reason. Thank you very much.
Please stay. Thank you very much. We have time for some questions. Are there any questions? While people are thinking about questions, I have a couple of ones. You say that you could find a cause for every case of dissatisfaction. Do you think there are other reasons than the ones that you didn't find, that
Yes.
can't be found?
Yes, absolutely. There are reasons for people to hurt that you can't find. And I think one of my one of the things that helped me out the most with these patients was my ability to talk them out of it. If they didn't hurt for a reason, I stuck with them and showed them that we were going to do everything in the world for them, and I mean test after test. And then I finally got them to say, well, it doesn't hurt so bad that I need just surgery anyway. So I do, and there are patients even that you can never get to that point. It's just, I think if you're careful, they're not really common in your practice.
So you mean that if you can't find a reason, and or you try to find a reason by looking at them several times, not allowing them to disappear, so they seem satisfied with the efforts you've done to find something, even if you fail to find something in the end.
I think that's a major part of it. They finally developed some trust in the surgeon and the system that they're working with, that they go away with a reasonable feeling about it. My point here, though, is if they have an effusion in their knee or a hip that is clearly a limp that you can see in the parking lot as well as in your office, then most of the time in my practice, something's really wrong. Something is really wrong.
You said that you found the cause in every case. Did you find a treatment for all the causes to dissatisfaction?
I did, except the spinal cases didn't always lead to satisfaction. I used an inversion table, used a physical therapy regimen, and rarely sent them for spinal surgery. That's one big group that you can't always totally fix. You know, they have to live with that terrible spine that we get as human beings, so I must say, other things such as ones that I have in my practice now, which have metal sensitivity in the knee, I know what it is, I just can't fix it yet because we don't have an FDA-approved ceramic joint yet.
See, about metal sensitivity, how common is it, do you think? You showed us 7 cases in a many years practice.
Yeah, no, I've got a lot more than 7. I probably have 100 or so. But those are the 7 that I could clearly identify. I have to send them away now because I don't have a reasonable solution for them. Nadim Halab, the world's expert on this and the one who knows the statistics, says it's about as common as infection. 2%. If you look at failed joints, failed knee replacement especially, it's 5 to 10% of those cases show up as metal sensitive. So it's more common than you think.
On the other hand, I assume that every knee, in this case, do abrade or roughen up the metal surface. Why aren't there 100% metal sensitivity?
Yeah, I think we get by with it better than you would imagine. But if I were given the choice, I was given and handed the ceramic porous-coated knee and the cobalt chromium porous-coated knee and asked which I would take the ceramic one every time, just as I would take a ceramic femoral head on my total hip.
Are there any more questions? No one? One last question. In Southern Europe, Italy, Southern Germany, they talk very much of cement allergy.
Yes.
What do you think about that?
I think it's a real entity. Cement allergy can be detected with skin tests and also lymphocyte proliferation tests. And that's highly treatable. It's treatable with revision with cementless joints.
Okay. So if there aren't any more questions, I think thank you very much.
Thank you.
We will have in the second symposium we will have after the break, after the 2 next speakers, there will be a discussion about things with a panel. We're going to sit there. The speakers and a couple of others are going to talk there. Now, let's go to another issue. Sara Gardestam, please come forward and present yourself and tell us about what people who are subject to late cancellations of planned surgery, how do they experience their situation?
Okay, so I'm Sarah and I'm a resident at Karolinska sjukhuset at the orthopedic clinic there. And I'm going to talk about the other bad things rather than the surgical technique. So I've done an interview study on patients that their surgeries have been cancelled with short notice and only elective hip and knee replacements. And the cancellations, they are not due to not cause of the patient. I mean, not the upper respiratory tract infection or Lyme disease, or they have a wound in the surgical area, or personal reasons, the moose hunt, or they want to go skiing instead, or they've changed their minds. No, the cancellations on short notice can be 1 to 2 days before surgery, or even in some cases, same as on the same day. The patient has come to the ward, and then there are no more OR time. We are short-staffed. There are not enough personnel in the operating theater, not enough anesthesiologists or nurses, or the ward is full of emergency cases. The fracture seasons, we have a problem. January, February, it's slippery outside. Or, as in the UK, for 2 years ago, they had a high peak of influenza. And that occurred on the same time that they were severely understaffed. And in the UK, at the time, they canceled 50,000 elective surgeries during the month of December and January. So I have done an interview study. I've done it's a semi-structured interviews with 12 patients from Karolinska sjukhuset that had been canceled on short notice. I called them up and asked if they wanted to be a part of the study, and I went to see them at their homes, dressed as a normal person. I didn't come as a doctor to them. So that they could, and they all wanted to tell me in great detail how they felt. And when analyzing the data, 3 big themes occurred. The first was how they had prepared for the surgery. It was a mental preparation. It was like to prepare for a game, but for the Olympics. I mean, this is a big event in a person's life. For most people, it's the first time that they're having surgery, and it's a big operation. And many has been in pain for a very long time, and they are finally looking forward to living their normal life again, playing with the grandkids or go out golfing. And also the practical aspects. They have to find replacement at work. Maybe family members must travel to come and take care of them after surgery. And someone must look after their dog, their horse. They have to go to the bank. And the next theme is the cancellation. All patients could, they described in detail what they were doing when they received the call. And they knew the second they got the call what it was. When the call came, I saw it was a hidden number, then I knew. I fell apart, started to cry, and had to lay down. So this disrupts their lives. They describe disappointment, of course, and also apathy. All the happiness disappeared. They feel like they're in a bubble. They can't partake in a society anymore. For some patients, they gotten replacements at work, so they can't go back to work. They have to continue to be on sick leave, and they are in pain, and they can't have, and they are very disappointed, and they are having troubles to go out and socialize and live their normal lives. And they are angry, very, very angry at the system. They think that the system is using them. There's never supposed to be an empty bed, never an empty operating theater, and the schedule must always be full. And I mean, they are partly right. And also, they worry about the consequences. If they get canceled again, what will happen? They will have financial problems, not be able to work again. Yeah, and the game is canceled. The ones preparing for the Olympics, no Olympics today. And the third team that occurred was waiting for surgery again. Now they are in the bubble. Their sleep is affected, they worry a lot. Many patients describe that they have more pain than they did before the cancellation. They must reload for the surgery again, and it's hard to do it once again. and the rehab. They worry a lot about the rehab. Will it hurt more? They think that, well, now they have more time to worry than they did before. Now I have the time to worry. And disbelief. Could it happen again? I won't get my hopes up. Will it be a surgery or not? Will I get a new date? Or will I come to the ward again and they will cancel me a second time? And one even said that if it happens again, I won't do it. There won't be any surgery. And can I really trust them? So now you have a patient who's going to undergo hip or knee total replacement. They are angry, they don't trust you, and they are in lots of pain, and they feel apathy. Maybe not the best situation to have big surgery, right? Moran et al. In 2003, it's a UK survey. They sent out 400 questionnaires to evaluate their concerns before total knee and hip arthroplasty. And number one was fear of being cancelled. Number one. 2, 3, and 4 was failure of surgery to reduce pain, loss of a limb, and joint infection. But the number one fear was of being cancelled. So, what to do? I mean, we as doctors, we do not cancel our patients if we don't have to, right? It's a system error, what we're working with. And it's really common in Europe, don't know in the US, maybe you do the surgeries that you're supposed to. In the Middle East, they have another problem. Their problem is like ours with the moose hunt. The patients, they don't show up. It's not really like as common here, but. So I don't have a solution. It's a political solution. You have to separate the elective division, the wards and the operating theaters from the non-elective functions. If you can have it 2 different hospitals or in the same hospitals that you close the admissions for the emergency cases. That would be the best solutions. Okay. Thank you.
Thank you very much. Thank you very much. Are there any questions to Sara? I see no one, but I have someone. Yeah, there, please.
Thank you for an interesting talk, because you really care about your patients, and I like that. My question is, during the time, did you give any advice for the patients to be better prepared for an operation? For instance, doing some of the rehab exercises that they should do after the operation so that they have something to believe in, something to do, and which probably, according to science, could improve their outcome?
No, I didn't, because all the patients, they partake in a... We also have 3 more studies on the subject that they partake in to see... we have hard data now that we're studying to see how the cancellation affects the final outcome, to see if there's a difference between the 2 patients group. And we also look at complication rates, if there's a difference between them. So no, I try to do as little as possible. But that is a very good point of view, because most patients, when they get cancelled, we cannot give them a new date. On the same call, we can't say, I'm really sorry, but you will have the new surgery in 3 weeks, because we have no OR time. And so for the patients to get a new operating date at the same time would be ideal, and also that we could support them during the time would be great. Yeah, I agree with you.
So it means that we don't know the results of surgery done on patients who have had cancellation beforehand with short notice. We don't know for sure how they feel about the results. These patients that you interviewed, did you ask them afterwards when they got their surgery if they were experiencing any problems? Or we don't know that either?
No, we don't know that either. Professor Per, that will be our next study.
I see. Okay, I don't see. Yes, there, please.
Thank you, sir, for a very interesting study that you've done. I'm wondering actually who's the one who's going to do the call, that you're going to make the phone call to them to cancel it. Because I can say that this can be different kind of cancellating as well, but who's taking like the decision that we're going to cancel, who's making the call to the patient, and is it that we actually can do something more, that a nurse the day after actually can call them and like check out how is you, how do you feel? Have you talked anything about that?
Yeah, these patients, when they were cancelled, they all received a doctor's call. Their surgeon called them. And now at Karolinska, we have a follow-up call a couple of days after, but we still have the problem that we can't give them a new date.
So that's the big problem, actually, that they don't have the new date. Okay.
Please.
Hi, thank you, Sarah. Did you also compare the patients that didn't get the call from the doctor? Because as a nurse or orthopedic planning administrative person who's making that call, it's a big burden to talk to that patient. So did you speak to the patients who didn't get the doctor's call?
They all got the doctor's call.
And you didn't speak to any patients that didn't get that call? Okay.
No. They all got the doctor's call.
Are there any more? I can see. No? Thank you very much, Sarah.
Thank you.
Well, please, Amir, come up. And please present yourself and the topic about the dissatisfied patient.
Yes. Thank you very much, Mr. Chairman, and for Ranger for Swedish Orthopedic Association. I will take actually the next slide, the first one. This is the second one. To be in the discussion session. No problem. So, why are the patients discontented after total knee arthroplasty? We may assume that this is a cause-effect relationship or a quantitative study, but it is not. We asked the patient why you are discontented after this procedure, and the answer came in this study. So, these are the co-authors, and as we said that there is between 6 and 32% which is not happy after this procedure. In Sweden we have about 8%, and most of the previous study, as we said, that it's quantitative design. There is lack of direct face-to-face interview. We assume that if the patients get a pretty prosthesis after the procedure, we will be happy and satisfied, like in these cases. But are the patients going to be satisfied? Not necessarily. And that's what was the purpose of this study, to see the patient's experience after discontentment. We ask them why you are not satisfied when the surgeon assesses it as a successful procedure. We send the letters for 356 patients, and we exclude the patients which not responding and those who was satisfied, and those who had a complication. And we end with the 44 patients. I interview 43 patients, and my co-author interviewed the last one because it was my patient. So it was a semi-structural face-to-face interview, which was analyzed by a qualitative content analysis. There were no big differences between the demographics between the groups relating to the gender or the BMI or the background, if it is a Swedish or non-Swedish background. There is no statistical test to demonstrate these because my co-authors like that this study would be qualitative, but no really quantitative designs. But we get these matrices. So still that we have the unfulfilled expectations and the need is taking the main contributory factor for all of these factors. So we're starting with the patient's interview, condensed meaning and codes, and the codes form into subcategories, and the subcategories forming and merging into these subcategories. The first one was unresolved and new problems, which made the patients unsatisfied. And we can classify that the problem with the knee, problem with other parts of the body, and worrying that changes might be complications. So the problem with the pain and stiffness, we calculated by an vivo software program for interesting sake, which was the main or the words that mentioned by the patients most, and we saw that the pain and related terms was most mentioned by the participants. Stiffness and its consequences in sitting, standing, or stair climbing, or daily activities. Sensory disturbances, not only cutting the sensory nerves around the knee, or rather than the strange feeling of the knee as described by the patients. And the cosmetics are not least. Problems from other parts of the body. Many patients tend to operate the knee when they have osteoarthritis and to relieve the knee, the hip pain or pain in the spine or the other knee, but unfortunately they didn't get the expected results. Worrying that changes are complications. So why I have symptoms which continued? Is there any complications that happen during the surgery, for example, detached ligament fracture or something like that? Or as a consequence to the surgery, thrombosis, I have inflammatory changes that may initiate cancer or something like that. This is the wondering of the patients that made them anxious. The second one is the need for buttresses, which was also formed by 3 subcategories. The first one is lack of respect of continuity. When the surgeon told the patients that the surgery is expensive, you have to wait with it, or the obesity is a problem, or the surgeon didn't introduce himself or herself, or non-understanding of the symptoms when I search about the symptoms. Continuity of the same surgeon was also mentioned, and non-continuity of the professionalistic or physiotherapist, and long waiting time for the surgery. Healthcare support mentioned as a lack from the patients. When patients feel that they've fallen between the cracks, for example, you get the patients with osteoarthritis and sending the patients to cardiologists, endocrinologists, just to solve the other problems in the background, and take a long time while the patient's waiting and suffering. And lack of economical support also. Informations which adapted to needs. As I said previously, that the participants said that the information was excellent, but when we asked them about the improvement field, they said information again. So informations that generally about the surgery and the expected recovery, risk of the surgery. Is there any alternative surgery? Many people didn't know about there is an alternative surgery. They didn't know that we're operating only 30% of the patients with osteoarthritis, for example, and there is another modalities we can living with osteoarthritis. Individual training program before, after surgery, or short hospitalization time. And the last one is the limited independence when there is inability to perform my daily activities. And described by the patients that was a reasonable expectations to do my daily activity and reasonable walking distance, which was not happened as expected. And that subcategory was very disappointing for the patients. Many people, when they end to ride a bike, for example, or dancing, and they hoped to do these activities after that, and they didn't get any of these. So how many regret surgery despite no obvious complications? If we take from the discontented people, which were 44 people, 10 people said that they was totally regretting surgery. They would never do it. But the rest, they said that we got a positive results, but it was not as expected as we thought. If we take from the total sample, so it was 2.8% of patients that regretted surgery despite no obvious complications or obvious reasons. I think that this study was the basis for further study. I collected already prompts data and sense of coherence and HATS data, but the material was very, very big, so I didn't mention anything about that. But hopefully it would be in the future study. And what we recommend in this study is that before we starting with educating the persons, we have to educate the surgeon. Not only to do the surgery, rather to how to deal with the patients, your attitude to the patient. And surgery is not the solution for all kinds of the pain. The ability to choose the right patients is the key of the success, and general and adapted information for every patient. Continuity is preferable. And what we can conclude from this study that expectation is still the major contributing factors. And the expectations, I perform the surgery to expect to do better in the future. Factors defined clearly in the study, or more deeply, as I said, and all elements need to be explored and managed well. And this is the most important, meaning that the patient's contentment after TKA is a process which starts from the first visit and lasts when the patient decides to do that. Thank you for listening.
Thank you very much. While the audience are thinking of questions, I have a couple of questions. Yeah. You said that education of surgeons would be the first step. I'm going to have a course in knee surgery in 2 weeks' time. Yeah. So the question is, what shall I tell them?
Yes.
What is needed? What is the lack of knowledge that I should tell them in 2 weeks' time?
I think that we have mechanical and non-mechanical issues. When we started with the surgical procedure, how to do and perform the total knee arthroplasty, we know from the previous study that it is good and it's excellent and it's important for the patient satisfactions. But as we know, that even if you do the surgery well, you are not going to get a satisfied patients when the patient's asking for economical compensation, for example. I didn't get that. Or as I will mention in the next session, when there were a mild indication for the surgery, and the surgeon accepted the surgery, and afterwards, when the patient seeking advice, the surgeon blamed the patients that you did the surgery. So I mean, this is the attitude, how to inform the patients before, general and adapted information for the patients, how to deal with the patients. Sometimes it needs only informations. Many of these interviews, people get relief at the end of the interview sections when we took an information pass for them. So I mean, not only the mechanical, rather than the general attitude and how to deal with the patients as person to person.
Before surgery or after the complication?
Before, during, and after.
Okay. So, yes, please.
Again, Dahlberg, Lund University. Thank you. I think these are really good studies. But I believe you're aware of Ola Rolfsson's studies and the relationship between depressive patients and outcome. Do you have any idea in your patients here if they have any depressive symptoms and how that was related to their unhappiness?
That was good questions. My PhD thesis dealing with psychological upset and dissatisfaction afterwards. So this is part of the general study. So yes, there is. But in this material, which was consists of 44 patients, I did a sense of coherence and hospital anxiety and depression scale for these patients, and there were no difference between between the people. But we can see clearly, even if you didn't find any anxiety or depressions, these symptoms is sufficient to make the patient anxious. All of us can be anxious when I have continued pain and swelling, in comparison to others that get great results. So you're wondering why you have the symptoms. Is this loosening or cancer or inflammations or infections? So there is an anxiety and depressions in this subscale, but for the patients group per se, there were no who have more depressed or anxiety in this group, but it's real, it affected.
Again, coming back to how to teach surgeons.
Yeah.
What should be the focus in the preoperative talk when the patient comes first time, when decision about operation or not is taking? What should be specifically improved based on your research?
Well, it is hard to solve all the elements that the patient is searching for, because we used to have 20 to 30 times to examine the patients and talk with them and then dictating or all of these practical tissue.
Well,
But,
if we disregard of that, if we say based on your research we should focus on 1, 2, 3, well, of course we have to lengthening the time for each patient at the outpatient clinic. So, so give us
the prognosis. Number one, we have a procedure. You are not going to get a natural knee after the surgery. Informations generally, and asking the patients about the adapted informations, what you are going to expect to do afterwards. I mean, several people come can ride a bike afterwards, and when it was difficult afterwards, so it was very disappointing. So general and specific informations for the procedure. Risk of complications, yes, it's part of the general informations, but I mean, the patients come with unexpected factors. I think it's important to ask the patients what would expect it from you, and then trying to answer these questions, and then spreading the general informations more in booklets or the leaflets, or I mean, general information that not the time for the outpatient visit would cover at all.
Do we know that this is the patient's opinion about whether they got information or not? Could it be so that the surgeons, they thought that they had given the information, whereas the patient meant that they hadn't? We don't know really what has happened. My experience is that sometimes you know that you have informed everything, and still the patient says a lack of information is a thing. What do you think about that?
I think this was really mentioned by the patients, that they mentioned the general information was excellent, but then they'd like to improve the informations. Or they mean the information that adapted to their needs. In my first study about the informations, how to knee surgeons inform their patients, we are good in informing patients verbally. 92% of the knee surgeons inform always the patients, but we have to improve in written information, for example, and dealing with informing the patients about there is a dissatisfaction rate after the surgery. Many didn't know about that. We have to improve about taking the psychiatric history, for example, and this information. So even if new surgeons know about the predictors of the surgery, but there is an improvement field in the informations. We don't know if the information exact getting to the patients when there is a lot of information in the first visit, and these need to improve. Not necessarily directly face-to-face inform the patients. Other modalities, videos, modalities, or leaflet or booklet to inform generally and specifically about the surgery.
What about, since information is hard to take in when you hear it once, should we change our routine to have 2 or 3 talks with the patient in a couple of weeks before surgery, so they can go home then come back, see
Yeah.
you a couple of weeks later, and have a discussion one or more time before doing surgery. Could that be an improvement? Of course, it's hard to implement that, of course, in the situation we have in Sweden, but from a theoretical point of view, would that be better? Or should it be done by someone else? We have now in the fast-track situations that people come back and they see nurses and they see physiotherapists after the decision of surgery have been taken. But should we also have the surgeon to talk to patients more than once?
Well, the answer theoretically is yes, about the informations. So if the patients have a time to read and understand the concept of the surgery pre-operatively, under and post-operatively, and about the prognosis as well, and asking about their real expectations to perform after that, and coming with the answers, then we get more satisfied patients. And we have examples in Sweden also. We have examples about the hospitals that doing on same manner, total knee arthroplasty, the same procedure, but they get more satisfied patients because they have more visit or telephone visit or informations for the patients, and that what made their patients more contented.
We have a little bit more time. I have another question. Yes, please.
Thank you very much, Amir. Very good. When you talk about the written information, do you think we should make more brochures, more sort of go in on our app and read yourself? Or how do you think about, for instance, patient contracts? Like you sit down with your patient, reason through, this is what we can deliver, what are your expectations, and then you sign it there and then? Is that an option to actually get it to land afterwards, that this is what we told you?
Yeah, well, written information is a broadly term. I mean, the internet and the books or brochure, something like that. Everything that talking about the general and specific issues about information. So yes, I would recommend it for the patient. And we saw with our study that only 42 or 44% of the knee surgeons always taking consideration of written information, just talking verbally of the patients and satisfied about that. And we know how the time in the outpatient clinic and the practical issue.
Yes.
Did you also compare or look at the patients who were Swedish-born or from abroad, about the information, how the expectations was or the result was from the operations?
Not deeply, but as you saw in the demographic data, there were no differences between the people who have a Swedish or non-Swedish background. As I said, there were no statistical. I don't know if you see it here. Oh, do you see it? Oh no. Here we see the background. Swedish background were 93% of the people have a Swedish background, and 7%, 3 people, from the discontented people, non-Swedish background. But they were talking good Swedish, so there is no mismatch in the understanding. And if we're taking the satisfied people, 96% was satisfied and or Swedish, and 4% was a non-Swedish background. There is no p-value or no statistical view, but you can roughly see that there were no difference in this group material, at least.
But do you feel as a doctor that the information or lack of information is harder when you have a patient with a translator or something like that?
The people that I interview didn't have any problem with the Swedish language. Not as a native speaker, of course, but I thought that they get the right information, so they understood the procedure. Because when we started with the interview, the patient started to talk about the pre-operative period and the informations and the expectations. And you can see from the interview guide and text that the people understand it pretty well. I understand your questions, but it was no problem here.
Okay, thank you. This seems to conclude the session. Thank you, speakers.